Welcome back to another video in this series talking about pregnancy, pelvic girdle pain, and all things related to trying to get you better with pain with pregnancy. This video is going to be mainly geared towards my physical therapist in regards to manual techniques that you can use for a patient that has pelvic girdle pain, back pain, things like that. So if you're interested in learning more, then keep watching. We're going to keep things really basic for this video and make sure that anyone that is an outpatient orthotherapist like me has the tools and the means to be able to help your patient. So you don't need any type of pelvic certifications, and just always make sure that you refer to how your patient is feeling and how they're responding in regards to the suggestions and recommendation in this video for how to treat with these manual techniques. First thing to consider with manual techniques with a patient that is pregnant or has pregnancy pain is that you have a level C evidence in regards to how effective this approach is. And that also includes things like your high velocity, low amplitude techniques or your HVLA. We'll circle back and we'll talk about this technique for considerations and other things that go along with it. But before we go there, we have to talk about treatment positions for how we're going to treat our patient for our manual technique. First thing you want to remember is if your patient is past 28 weeks in gestation, typically into the second or third trimester, you don't want to put their patient flat on the back. That's going to increase the inferior vena cava pressure and cause complications that you don't want to get into while you're in your treatment session. One thing you can do to get around this is maybe adding a little bit of incline in your table, about 20 to 30 degrees. And like I said, watching for how the patient is responding, making sure there aren't any signs of profuse sweating or changes in their awareness, things like that, to make sure that the patient is responding well to this. Or you can pivot all together and try a sideline positioning technique for whatever manual intervention you're about to do. When you are choosing which side to lay on, it does make a difference. You want to try and lay on the left side to promote the best circulation for the patient and their baby. Now let's get to the fun part, some of our recommendations for manual techniques that you use. This is not going to be an exhaustive resource or list, and we can't get into the meat and potatoes of every technique. But to start off our list, we talked about manipulations. One thing to consider with manipulations is that the patient will likely have increased laxity in their joints because of the changes in pregnancy. You also have options for doing METs or muscle energy techniques, visceral mobilizations. Trigger point and soft tissue is an option as well, in addition to dry needling. Now we'll spend a little bit of time talking about dry needling just because it is a little bit of difference in research and clinical practice and opinion. So we'll get into those things today. And this is going to be geared towards anyone that is, of course, dry needling certified, or you have a clinician that has this certification. Briefly, to give you background, if you aren't familiar with dry needling, it's a technique used in Western medicine that physical therapists are certified in or can get certified in, that uses the same tool as acupuncture, but it has the idea behind it of Western medicine for creating good inflammation, blood flow, decreasing pain, increasing range of motion, all by if you're going into the muscle and basically getting deeper into the skin than what you can do with your hands. Now that we've gotten that out of the way, let's get to the juicy details about dry needling during pregnancy. I'll try and leave the exact quote on the screen right here, but I'll summarize the quote that the APTA actually released in 2013, basically saying that dry needling in the first trimester can be fairly common with causing miscarriages, but not to say that there is any type of evidence to support that dry needling can actually cause abortions. The Dry Needling Institute American Academy for Manual Therapy is also a resource where I found a bulk of information and summarization in regards to the success or the approach for dry needling during pregnancy. And they included tons of references for randomized control trials, different types of clinical approaches that they have looked into to kind of decide the success and weighing the risks and benefits. Now keep in mind, this list of research is probably not exhaustive. In that regard, just remembering to have the safe and the best practice and using your clinical judgment as I present this information for how we can implement dry needling as a consideration. Overall, with all of the research that was presented with the Dry Needling American Academy for Manual Therapy, it was concluded that there's moderate quality evidence in regard to dry needling during the pregnancy of a patient can help with pelvic pain or lumbopelvic pain. Now, with these considerations, there is a suggestion that you want to consider how many needles you're using, where you're implementing them, how long you're leaving the needles in for, and then also if you're using TENS unit or electrotherapy in conjunction with the needling. It is recommended to avoid using the electrotherapy or TENS unit while you're doing the dry needling, just like you would avoid doing ultrasound or TENS on a patient that's pregnant, and being considerate to those modalities and any type of effects it could have on the pregnancy. But overall, the current evidence says that there are several professional organizations that suggest that dry needling can be useful during pregnancy, and it should overall be looked at as more as a precaution and not a contraindication. This, of course, is going to vary on a case-to-case basis based on your clinical judgment and doing the research to know your patient and the risk and benefit. Other techniques you want to consider are internal versus external. So, like I said, this is going to be for everybody that's going to be doing external interventions as far as manual techniques for a patient with pain with pregnancy. But also know that you have your pelvic floor specialist, physical therapist that can also introduce internal techniques that can help the patient if that's the direction they're needing to go. Now we'll talk about areas where you might want to implement some of the interventions as far as trigger points and things. We know that there can be muscular referrals, so common muscles that could be the culprit in the pain that's being referred, but are often forgotten about, are the obturator internus and the abductors. For the abductor specifically, we know that that can cause some groin pain, and the anterior medial aspect that can go down the knee even to the shins. So it could be a place that you want to address or investigate when your patient comes in with pain complaints in those areas. For the referral pattern for the obturator internus, the patient could complain of pain going down the back of the ipsilateral thigh. As we discuss manual techniques and things you want to do to get your patient better, you want to know if you're actually getting your patient better. So we will touch on outcomes briefly so you can know what tools you can utilize to track your patient's progress. The pelvic girdle questionnaire is one thing that has good reliability and validity in regards to a patient with pelvic girdle pain. It's a 25-item questionnaire that's scored out of 100, with the higher score relating to higher severity or impairment. And just before we go for today, we will discuss some of those red flags for what you want to watch out for with the patient if something is not right, and also a little bit of when to refer. I won't rattle off the comprehensive list here, but you will have the list down in the description box. But some things to watch for and to possibly take note on in your history and subjective intake is if the patient has had chronic vaginal yeast infections, if they've had a history of abortion or miscarriage, if the patient has endometriosis. Reproductive colon or breast cancer are also things to consider when you're treating a patient. Recent intrauterine contraceptive device that's been placed is also something that you want to be aware of and take note of in your subjective history. And in a future video in this series, we'll also discuss the things to look out for with urinary incontinence. So if you have a patient that complains of the pain with your pregnancy in conjunction with some bladder leakage, things like that. Watch out for the next video that will go into detail about what urinary incontinence is, what you can do to treat it, and when to refer for that condition. That's all the information I have for you today for this video. I hope you got some good information and learned a few new things. As always, these are recommendations based off of a licensed physical therapist, but consult your most recent research depending on when you're watching this video, your healthcare professionals for your patient, and also your patient themselves to make sure they understand the risks and benefits and the procedures that you're actually going to implement on them. If you have any other questions, please just leave a comment in the chat box, and I look forward to seeing you in the next video.